Hi everybody. Today's video will be on the topic of the video will be on humerus today. Okay, humerus, as you know, it's a humerus bone. Well, some of the jokes are also made on the humerus, in that we're going to look at it later on, the funny bone, and this is basically related with the ulnar nerve. When you hit the ulnar nerve, it gets tingled, and your forearm, your hands gets numb, and it is referred to as, well, you hit the funny bone. Okay, so it is also regarded as the funny bone because it's, if you look at the spelling, it's humerus, but the funny part of this bone is humerus. You know, although the spelling is really similar, the writing of the words it's really different. Okay, so this is the humerus here. All right, so humerus is one of the important bones of the upper limb, and it is the longest and the strongest of the upper limb. So when we look at the upper limb bones, we have the humerus, and then we have the humerus is basically the arm bone. The bone that is located in the brachium, and then we have the forearm bones, the medially located ulnar radius, and then we have the wrist bones, and then we have the fingers, the digits, and the phalanges. So humerus is basically one of the important, strongest bone present in the upper extremity, upper limb, and it also bears a high amount of weight of the lower limb. And one of the important functions, of course, is the attachment of the variety of muscles. And this variety of muscles basically it attaches to the humerus, so basically it also acts on the movement of the arm plus the movement of the forearm. So some of the muscles originates from the humerus, and it goes and attaches to the forearm, and basically it moves the forearm. And some of the muscles originates from the clavicle scapula, and then attached to the humerus, and then basically moves the arm in various directions. Okay, so as you can see, humerus, it has a proximal end, a distal end, a shaft in the body. This proximal end attaches to the scapula, and in our previous videos we did the scapula. We discussed the scapula, and there's the glenoid cavity here in the scapula. And then we're going to look at the humerus in details a bit later. But the head of the humerus attaches or articulates with the glenoid cavity or glenoid fossa, and basically forming the shoulder joint, or we could also refer that to as the ball and socket joint. And the way that they attach is that the head, if you look at the glenoid cavity of the scapula, it's not really shallow, it's not really depressed, or it's not the shallow part is not deep. It's really slight superficial, and therefore it allows the head does not go deep inside the cavity, so it's like superficially located. So basically, the significance of this position, the morphological position, is that the humerus can do a variety of functions in this attachment or in this articulation. So it can flex the arm. So this is flexion here, as you can see, and it extends the arm. It abducts the arm, abducts, and adducts, come back, and forward. It also does the pronation, medial rotation, and supination, lateral rotation. And of course, it does the rotational movement completely surrounding the joint capsule, and this is basically the circumduction type of movement. So it does a variety of functions in this particular joint due to the attachment or articulation of the head of the humerus and the glenoid cavity. Okay, as you can see, so we have the shoulder joint here at the proximal side, and then we have the elbow joint here, and it's via the elbow joint it attaches, the humerus attaches to the ulnar and radius, forming the elbow joint, or humero-ulnar radial joint here, a joint that joint that is made out of three bones, participation of the three bones. Okay, so this is about it. So after giving brief explanation about the general aspect of the humerus related with the articulations of other bones, so let's look at the humerus independently now. And look at the individual and detailed structures. Okay, let's look at it now. Okay, now we're going to look at the detailed structures on the of the humerus, the landmarks and the different aspects of the humerus. So as you can see, humerus is a long bone. All right, so it is formed by three parts. The upper part. So this part here is the upper part, and then well, this is the proximal part. And this is the body, this is the shaft, and then we have the distal part, which is the lower part, lower end of the humerus. Okay, as you know, the proximal word. Why do we use this word? Because it's very close to the body, and distal is away from the body. That's why we use the distal. And if it's close, it's proximal. So this is the proximal end, or the upper end, the distal end, lower end, and then we have the body and the shaft. And we're going to look, and then we have we have three borders. So we're going to look at the three borders. Then we have three surfaces, and we're going to look at these borders and surfaces a bit detailed a bit later. Okay, let's start looking at the upper end now. Okay, so upper end, as we can see, and also one other thing. So we're going to look at the features, the external features. After examining the external features, we're going to look at the right or left humerus. So, what important features do we need to know in order to say that the humerus is right or left? So let's look at the features first, and then we'll decide the humerus if it's left or right. All right. So let's look at the upper end now. The upper end, the proximal end of the humerus, this part here, it is primarily made out of this circumferential head. So we have the head here. Okay, so this is the head of the humerus. As you can see, it's round, circumferential, and it's smooth. And this smooth area is basically covered by articular cartilage, hyaline cartilage, and it's thick in the middle, and it's a little bit thinner as we go along to the periphery. So this is the head of the humerus. One thing is that in anatomy, when we look at the bones, not always the head is located at the proximal. So we're going to look at the ulnar, for instance. The head of the ulnar is located at the distal end. So it doesn't mean that the head is always proximal. But here in humerus, yes, it is located at the proximal end. And the head basically articulates, like I said, with the glenoid cavity of the scapula. So if we look at, for instance, this bone, I don't know if you can see it. So this is the head of the humerus, and this is the glenoid cavity of the scapula. Okay, so there's an articulation between these two structures, and we call that glenohumeral joint. This is the glenohumeral joint, and this is the shoulder joint. Okay, so all right. So, but if you look at the head, how is it oriented? For instance, so we have, this is medial located. Okay, so one of the criteria of the position of the head is that it's medial located, and it's slightly it's facing upwards. So if there's there's a line, horizontal line. So if you can see it, so it's facing upwards. And if you look at it from the top, it's slightly backwards located. So if the original position is like this, so the head is slightly faces backwards. Okay, so it slightly faces backwards. It's medially located, and it's medially located. It's slightly backwards, and it faces upwards. So those are the three criteria of the head of the humerus. Okay. So this is the head of the humerus, And just below that we have the neck. Okay, so I'm outlining the neck here. So this is the neck of the humerus. This is the neck, but we have two. Actually, we have three necks. We have an anatomical neck, surgical neck, and morphological neck. The thing that I outline is the anatomical neck. So anatomical neck is basically this area. It's between the head of the humerus and the rest of the shaft. So this is the anatomical neck. And then we have the surgical neck. Surgical neck is over here. Surgical neck is just below these protuberances, these tubercles. This is the surgical neck. This is the anatomical neck. And then there is a morphological neck. I'm not going to go in detail, but morphological neck is basically you don't see that adult's bone, and it's a closure of the epiphyseal cartilage. So we have the diaphysis and epiphysis, as you know, and then we have the epiphyseal line or metaphysis. So that's a remnant. The epiphyseal line is basically the remnant of metaphysis or epiphyseal cartilage, and after adults, it basically disappears. So that's the morphological neck, and it's basically located just beneath the tubercle, but you don't see that. So that's not a big deal, no morphology. But the two important necks that you need to know that is important is the anatomical neck and the surgical neck. Okay. So anatomical neck, as you can see here, is slight indentation. You can see it, an indentation here, and this is basically the line of the capsule, the attachment of the capsular ligament. So capsular ligament, or the joint capsule, attaches to this anatomical neck, this indentation, the depression, and this capsular ligament basically circumferentially covers this articular cartilage. And one of the two areas that the articular ligament is deficient, or it doesn't attach to this line, is the two areas. One is this sulcus here that you see here, and this tubercle is basically I'm gonna explain these a bit later, but there's a ligament that attaches these tubercles together here, transverse humeral ligament. So the articular capsule, articular ligament, basically attaches to all of the impression or indentation, and it's only deficient over here where it attaches to the ligament here on the superior side. And on the medial side, the capsular ligament basically does not attach on the medial side, because all the way down to the shaft here. Okay, so there's ligament that attaches to all the places, all the areas of the anatomical neck, except on the superior side, where there's transverse humeral ligament, where there's this intertubercular sulcus here, and this is on the superior side. On the medial side, this ligament goes beyond the anatomical neck and goes all the way to the shaft. Okay, and this enables for the abduction function to be more appropriate. Okay, so that's the articular capsule, articular ligament. Okay, if we go down a little bit, again, we're still continuing to the at the proximal end. So two important features that we see here in the proximal end, on the upper end, is these two protrusions of bony protrusions. The one located on the anterior side and one located on the lateral posterior side here. So basically, this is the anterior. Okay, so this is the anterior. So this is a little bit smaller. We call this as lesser tubercle. This is a little bit larger, and it's located superior to the lesser, and we call this a greater tubercle. So this is lesser tubercle, and this is the greater tubercle. And in between these two tubercles, we have a depression, a sulcus, and it is referred to as intertubercular sulcus. All right. So this is the intertubercular sulcus, and one of the important structures passes. Well, this is also referred to as bicipital groove. So we can call this an intertubercular sulcus or bicipital groove. The reason why it is referred to as bicipital groove is that the important structure passes through this groove, and that important structure is the tendon of biceps brachii muscle, along with its sheath, of course. So that passes through this groove, and that's why it is also referred to as bicipital groove. As you remember, we had the tendon of the biceps brachii originated from the supraglenoid tubercle. So basically, the biceps brachii muscle passes through this groove and it goes inside the capsule, and then let's look it over here. Okay, so it's like this. So the tendon of the biceps goes through this groove, this intertubercular sulcus, the bicipital groove, and then pierces inside. It goes inside the capsule. It becomes the intracapsular, and then goes all the way to the supraglenoid tubercle. As you remember, when we examined the scapula, discussed scapula, we talked about supraglenoid tubercle and then infraglenoid tubercle. So supraglenoid tubercle is the origin of the biceps brachii muscle. Okay, so it goes down. So that's how it goes upwards. All right. So that's that. And also, along with the tendon of the biceps brachii, we also have the ascending branch of the anterior circumflex femoral artery. Also accompanies the tendon of the biceps. All right, so this is the lesser tubercle, greater tubercle, bicipital groove. Inside the bicipital groove, we have the tendon of the biceps brachii muscle with its sheath, and also accompanying it, we have the ascending branch of the anterior humerus circumflex artery. Okay. The greater tubercle, if we look at the greater tubercle here, we have three impressions. The superior, middle, inferior, and these are the attachment sites of important muscles. The superior impression, so we basically designate them according to their first letters, which is SIT, S-I-T. It's supraspinatus, infraspinatus, and teres minor muscle. So supraspinatus, infraspinatus. You remember supraspinatus, infraspinatus muscle were located in the scapula, in the supraspinous fossa and infraspinous fossa. We talked about those in the scapula, and then we have teres minor muscle, which is also associated with the scapula. So these three muscles attach on the superior border of the greater tubercle, and then we also have another muscle attachment of the lesser tubercle, which is subscapularis muscle. Remember, the subscapularis muscle attached to the subscapular fossa of the scapula. So this is subscapularis muscle, supraspinatus, infraspinatus, and teres minor. So these four muscles make up the rotator cuff muscles. The reason why we're going to look at these muscles in the muscle course, but in terms of now, the importance of these muscles is that they form the rotator cuff muscles. They're designated as rotator cuff muscles, and the significance of these muscles is to stabilize the shoulder joint, and it makes the shoulder joint more firm and strong and healthy. Okay, so those are the three muscular attachments there. Okay, next. Okay, so that's about it for the proximal end of the upper end of the humerus, and the other part is this, like I said, surgical neck. We're going to look at the. Okay, let's look at surgical neck. Surgical neck. Like I said, the reason why they called it as surgical is that one of the important areas that is fractured, fracture occurs in the humerus is at this particular site. So when you fell down, your arms open and your palms open, so so the load gets concentrated in this particular area, and this particular area gets fractured. This is one of the important vulnerable area of fracture of the humerus, and that's why it's referred as surgical neck. The reason why this is important is that just behind the surgical neck we have the axillary nerve passing behind at that particular site. Just behind we have the axillary nerve. And along with the axillary nerve, we have one of the important arteries, and that is the posterior humeral circumflex artery. So when fracture occurs here in a surgical neck, so the axillary nerve will definitely get damaged, and the posterior humeral circumflex artery will definitely get torn. The damage of the nerve is really important. Why? Because this nerve innervates. It's one of the important nerve of the terminal branch of the brachial plexus, and this nerve basically, with its damage, you would have non-functional of one of the important muscles, which is the deltoid. Deltoid is one of the important muscles that is innervated by the axillary nerve. Okay. So that's the so surgical neck. So don't forget, when you look when you think about surgical neck, when in fracture surgical neck we have the damage of the axillary nerve and the posterior femoral circumflex artery. Okay, as we go down, this is the shaft. All right. So all right, this is the shaft. Yeah, let's look at the shaft. So shaft. So we have 3 borders and 3 surfaces of the shaft. Okay. So this is the anterior border. As you can see, this is the anterior border. Okay, let's look at the borders now. So this is the anterior border here, and this is the medial border, and this is the lateral border here. Okay, so we have 3 borders. So we have the anterior border, medial border, and lateral border. In terms of surfaces, we have the anteromedial surface, anterolateral surface. Okay, this is the anteromedial surface, this is the anterolateral surface, and this is the posterior surface. So this is the medial border again. This is the anterior border, and this is the lateral border. Anterior border, as you can see, anterior border just lateral to the anterior border, or at the lateral part of the anterolateral surface, we have this tuberosity here. It's a V-shaped tuberosity. It's not really apparent here, but it's like a V-shaped tuberosity. This is called the deltoid tuberosity. So deltoid tuberosity is primarily located on the anterolateral surface of the humerus, at the upper part. And this deltoid tuberosity, basically, this is one of the important muscles attached in search to this area, which is the deltoid, of course. All right, deltoid muscle. So we have deltoid muscle, or deltoid tuberosity, located here in the anterolateral surface of the humerus. So the anterior border basically goes down and then basically fades away as it goes down to the distal end. On the medial border, this is the medial border here. Okay, so medial border is basically continues with I also should mention that. So we have lesser tubercle, great tubercle. As it goes down, we have these lips or crests as it goes down. The tubercle. So the lesser tubercle, as it goes down, we have the crest of the lesser tubercle is also referred to as medial lip, and the crest of the greater tubercle, as it goes down, it is referred to as the lateral lip. So we have the medial lip, lateral lip of the intertubercular sulcus, we can call that. So basically, medial lip continues as the medial border of the humerus, and and as it goes down to the lower third of the humerus, here it's sharp. Okay, so if you feel it, it's really sharp, and this is a sharp ridge, and this sharp ridge makes up the supracondylar ridge. Supracondylar ridge basically continues and connects with this prominence. This prominence is called the medial epicondyle. So this is the medial epicondyle. This is a supracondylar ridge. Okay, this is the medial border of the humerus, and it continues with the and attaches to the medial lip of the lesser tubercle, or medial lip of the intertubercular sulcus. The anterior border, as it goes down, like I said, the upper part crosses the deltoid tuberosity, and it goes down and basically fades away as it goes down to the distal end of the humerus. In terms of the lateral border, again, the lateral border, we basically see a prominent lateral border, the lower half of the humerus, but in lateral border, as we go up to the humerus, basically it's improminent. You don't really notice it. But at the lower part, again, it's also a sharp ridge, and this is called the lateral supracondylar ridge. Okay, so we have the medial supracondylar ridge on the medial border, and on the lateral border we have the lateral supracondylar ridge, and this lateral supracondylar ridge basically ends at the lateral epicondyle. So we have two epicondyles. We have the medial epicondyle, and then we have the lateral epicondyle. Okay. So this is basically this is basically it for the body and the shaft. Let's look at the now the lower end. So this is the lower end. Okay. Okay, this is the lower end or distal end of the humerus. So on the medial side, we have the medial epicondyle. Basically, we have articular surface and non-articular surfaces. Okay, and the articular surface is basically is comprised of two important structures here, which is the trochlear and capitulum. So this is the trochlear, and this trochlear is basically a pulley-shaped structure. Capitulum is caput, or the head-shaped, and these two structures make up the articular surface of the distal end of the humerus. And basically, these can be referred to as condyles because the condyles normally refers in anatomy in examining the bones. These are the sites of articulations. So that's why the non-articular surfaces or areas on the medial and lateral side, we call them epicondyles, above the condyle. Okay, so if we refer to these areas as condyle, so these are the above condyle, which is the epicondyles. Okay, but we don't call these condyles. We name them as their name implies, which is the trochlear and capitulum. Okay, the medial side is where the trochlear is located, and on the lateral side we have the capitulum. And then we have two important impressions of fossa. Above trochlear is the coronoid fossa, and this is the radial fossa. So we have trochlear, capitulum, olecranon, we have the coronoid fossa, and then we have the radial fossa. All right. So, and basically this distal end forms the elbow joint, and we're going to look at how the joint is formed. So, if we look at the posterior side, we have a deep impression. We have the deep fossa, a shallow area, a deep fossa, and this fossa is called the olecranon fossa. Okay, so we have the trochlear again. Looking at from the back side, we have the trochlear, okay, on the medial side, and the medial protrusion is the medial epicondyle, and then we have the capitulum. It's not so evident at the posterior side, and then we have the lateral epicondyle on the lateral side. Okay, so this trochlear, this olecranon fossa is really important in articulation of the and the formation of the elbow joint. So let's look at the how the joint is formed. Okay, so before that, after we learn these general overall information, so what can we say about this bone? Is it right humerus or left humerus? Okay, so let's say, okay, so the head of the humerus should face medially, okay, and that's one important criteria. It should face medially, okay. That's one. And second, the lesser tubercle should face anteriorly. That's second. All right. And then you have the medial epicondyle. It's more prominent. The medial epicondyle is more prominent than the lateral, so that also should face medially. That's three. And fourth important criteria is that the olecranon fossa. You see, this olecranon fossa is prominent and evident, this fossa, and it should face posteriorly. Sorry, it should face backwards. All right. So according to these criteria, is this right or left? So it should be like this, or okay. So if it's like left humerus, is this left humerus or right humerus? Let's look at if it's right. It could be okay. So the head of the humerus is medially located right. So it could be left, right? But we could also place it like this. It's also medially located here at this point. But however, in this particular position, right, the head is located medially. That's correct. This fits the criteria. But if you look at the distal end of the humerus, the olecranon fossa, okay, it's facing anteriorly. So boom, that's incorrect. Olecranon fossa should face what? It should face posteriorly. It should be on the back side. So this is the correct position. So if this is the correct position, this is and this is the left humerus. Also, we also have the medial epicondyle facing medially. But still, if it's on the left side, the medial epicondyle is still facing medially. Okay, this faces medially. That's correct, but your olecranon fossa is at the back. So basically, this is the left humerus. All right. So this is the left humerus. Okay, let's look at the attachment. So what happens is that here you have this attachment. So this is the ulnar. We're going to look at the ulnar and radius in later videos. So the ulnar attaches to the trochlear. So we have the ulnar notch. So this is the ulnar notch of the ulnar. Okay, attaches to the trochlear of the humerus. All right, and basically, so we have the head of the radius. This is the radius on the lateral side of the forearm, and it attaches to the head, the capitulum of the humerus. So this is how the wrist joint forms. Okay, so we have the trochlea, the pulley, the trochlea of the humerus attaches to the trochlear notch of the ulnar, and the capitulum attaches to the capitulum of the humerus attaches to the head of the radius. All right. So and then we have this elbow joint formed by the humerus, ulnar, and radius all together. And so what happens is that we had in the humerus we had this coronoid fossa here. And then we have the radial fossa. In flexion, as you can see, when flexion occurs, the coronoid process of the ulnar basically attaches to this fossa here, and the head of the radius attaches to the radial fossa of the humerus, like so. Okay, in flexion. At the back, if we look at the back, okay, and then we have the olecranon process. Olecranon process of the ulnar attaches to the olecranon fossa in extension position. So this is when extension occurs. Okay, let's look at this part here. This is much better. So this is the anterior view, both of the arm and the forearm. Oops, this is the other. Okay. Anyhow, let's look at this. That's left. This is the left humerus, and that's the right hand forearm. That's why. Okay, so the posterior part, as you can see, attaches to the olecranon process attaches to the olecranon fossa at the back. All right, that's it. All right, so okay, last let's look at the fractures. So we talked about fractures. Okay. What we said that the surgical fracture, all right, and the structures that can be affected would be the axillary nerve and the posterior circumflexhumeral artery. That's one. Second, I forgot to also on the posterior surface. Okay, let me rewind and look at the posterior surface. The posterior surface. Okay, here, as you can see, this is the posterior surface. Here we have the spiral groove, all right? We have the spiral groove, and this spiral groove, and it's also referred to as radial groove. It's very close to the deltoid tuberosity. So this is the deltoid tuberosity on the anterior lateral surface. Just behind that, just behind the deltoid tuberosity, we have the spiral groove. So this is how it goes. Okay, so this is a spiral groove. It's like an S shape. It goes behind, and then it basically curls around the mid shaft of the posterior surface of the humerus. This is a spiral groove, and the reason why the spiral groove is important, it lodges or accompanies of the radial nerve. So radial nerve passes through this groove, and it's a really important landmark. And so, don't forget that. The reason why I explained that is that I was talking about the fractures. So when you have the mid shaft fracture, which is if you fracture the humerus at this particular site, it's mid shaft fracture, and you would damage the spiral groove, and along with it the radial nerve. So the radial nerve would be damaged. Along with the radial nerve, there's also an important artery that passes along with the radial nerve would be the profunda brachii artery. So if you have mid shaft fracture, you would damage the radial nerve along with the profunda brachii artery. So if you damage the radial nerve is an important terminal branch of the brachial plexus, and it's an important nerve that innervates the extensor muscles in the arm and the forearm. So it's really important. So this is a mid fracture. Okay, in a clinically really important mid fracture. What else fracture do we have? We also have the medial epicondyle fracture. Okay, medial epicondyle fracture is important. The reason why is that you have the ulnar nerve passing just behind. Okay, just behind the medial epicondyle. So let's look at it from the behind. So ulnar nerve just passes behind, and we call this as the ulnar groove. Okay, it passes through the ulnar groove, and it comes at the anterior part of the forearm. So basically, it passes along on the posterior aspect of the medial epicondyle, and it curves around in the ulnar groove, and then goes to the forearm. So hence, therefore, if you have a fracture of the medial epicondyle, you would damage the ulnar nerve. All right, and there's also, in terms of artery, you have the medial ulnar collateral artery also passes through along with this nerve. So important nerve damage, medial epicondyle fracture is the ulnar nerve. Don't forget that. So that's 1, 2, 3. And the fourth important fracture is the supracondylar fracture. So if this is referred as a condyle, so this is a supracondylar fracture around about at this particular area. And in the supracondylar fracture, one of the important nerves can be damaged, susceptible to this fracture, is the median nerve. And the artery is the brachial artery. So you have the median nerve passing along on the midline, on the anterior surface of the lower part of the arm. So you have the median nerve passing through this along this road. Along with it, we have the brachial artery. So if you have a fracture on this side, so the median nerve and the brachial artery can be damaged at this. So we talked about 4 fractures: the surgical fracture, axillary nerve. Along with it, we have the posterior humeral circumflex artery will be affected. We have the mid shaft fracture, radial nerve, and along with the radial nerve would be the profunda brachii artery would be damaged. We have the medial epicondyle fracture. We would have the ulnar nerve and the ulnar collateral artery, and then we have supracondylar fracture, would be the median nerve, and the brachial artery would be damaged. Okay. One other important clinical aspect of the distal end of the humerus is that the medial medial epicondyle. The medial epicondyle serves origin for a variety of many superficial muscles of the forearm. So you have the forearm here. So many superficial muscles of the forearm originates from the medial epicondyle and then goes to the forearm and forms the primarily these muscles acts as flexors of the forearm. Okay, and likewise on the lateral epicondyle, again many muscles originate from this lateral epicondyle, and these muscles serves as extension, and these are referred to as extensors of the forearm. So we also refer to these protrusions, the medial epicondyle, lateral epicondyle, as the common flexor or common extensor origin. So this medial epicondyle is also referred to as common flexor origin, because most of the flexor muscles originates from the medial epicondyle, and then from the lateral epicondyle we have the common extensor origin. It's also referred to common extensor origin because many of the extensor muscles of the forearm originate from the lateral epicondyle. Clinical importance of these important areas is that on the medial side, because of the overuse of the muscles plus the overuse of the tendon, you have this medial epicondylitis, where the bursa between the tendons and the bone you have the inflammation of the bursa, and basically what we call as the golfer's elbow. Okay, so when the medial epicondyle gets inflamed or the bursa gets inflamed, we call it as golfer's elbow. However, in the lateral epicondyle, when we have the lateral epicondylitis, when the bursa is inflamed because of the overuse of the muscles and tendon, and then because of the friction occurring, and then because of the inflammation of this particular area, we have the tennis elbow. So basically, in the golfer's elbow, what happens if you look at my so you grip a golf bat, okay? When you grip it, so all your flexor muscles basically contract and they work in your forearm and your hand. So that motion basically allows the flexor muscles to work harder and much dense. So I'm sorry, on the medial side, of course. On the medial side, the medial epicondyle gets inflaming. However, on the lateral epicondyle, the extensor muscles originate. So this is the tennis. So basically, this tennis primarily when you do extension. So when you extend your forearm in the backhand during playing tennis, okay, this motion basically you're doing a lot of extension motion of the forearm, and that after a certain time gets the inflammation gets occurs at the lateral epicondyle, and you have the lateral epicondylitis, and therefore you have the tennis elbow. Okay, so that's the clinical importance of the medial and lateral epicondyle, and attaching the muscles and the tendons attaching to this particular area. Okay, that's about it. If you have any questions, I'll be around. Thank you very much for listening, and stay tuned for our next video. Thank you very much. Bye bye.